Hello and welcome to USBC's Racial Equity webinar series. I'm Kinkini Banerjee, the Coalition Relations Director at USBC, and I'm so glad to have you join us for this session. The USBC hosts this bi-monthly webinar series with funding support from the W.K. Kellogg Foundation. And the purpose of this series is to improve our collective learning about the principles of social and racial justice, inclusion, and equity, so we are able to elevate our action around health equity. Understanding issues of structural and institutional racism in the maternal and child health field, and knowing how to apply the equity principles in our work are core competencies for any practitioner or leader today. And this forum provides us a variety of opportunities to engage with each other, learn from each other, and collaborate to address inequities within our communities. So I hope you are a member of the Racial Equity Learning community. If not, please consider joining today. This is open to anyone in the field. It's an inclusive learning process, and we host a webinar at each odd-numbered month and post resources and shared materials. And we also have a discussion forum for folks to continue the dialogue and conversation beyond the webinar session so that we can share and interact and learn from each other. And we also, this learning community, as all of our others, also has a very rich file library. So we curate and share selected readings as well as readings related to each theme. So this, you will find resources that we will be posting today as well as in the coming days to add to our session today. So if you haven't ever accessed our learning community, this is how you do it. The website URL is www.usbreastfeeding.org/equity-community. But if that's a link that's hard to remember, if you go to our website, the homepage, and look at the tabs for news and info, click on that. And if you scroll down, it says learning. One of the drop-down menus is learning communities. Click on the learning communities and it'll open up more than 20 different ones related to the Surgeon General's action items. And so join the ones that that are of interest to you. And the racial equity learning community, you can see, is at the towards the bottom. They are arranged alphabetically. Today's all the slides as well as any other materials are on the webinar page. As well as you know, we understand that not everybody can attend these sessions live, so we record all of our sessions, and the up for you during the session, and you could be, I'll show you how you can do that. You can do that throughout the presentation today. So you should see a control panel on the right of your screen. If you don't see it, it might be minimized. So click on that orange tab with the white arrow and it'll pop back out. And you'll see the first tab is the audio tab, and just under it is a tab for questions. Click on it and it'll open up a box for you to type in. During this session, if you have any audio or other technical issues or problems, email office@usbreastfeeding.org and one of our staff members will be able to help you. And that brings me to today's topic, ASAP, Alameda County's Breastfeeding Equity Task Force for Asian, Southeast Asian, and Pacific Islander communities. Advancing breastfeeding equity in the U.S. Expands beyond a focus on individual behavior and, towards a wider range of social, economic, cultural, and political conditions in which mothers and their families grow and live. May is Asian American Heritage Month, and I'm so honored to have members of this one-of-a-kind task force tell us about the richness and complexities of this diverse population group and some of the factors impacting breastfeeding within these communities. We will hear how the ASAP task force really plans its strategic priorities and action plans with a deep emphasis on multi-sector partnerships and based on the strengths of the communities. We will learn about the terrific resources developed to support Asian API breastfeeding families, and how we will also explore how we can all be involved in supporting breastfeeding among Asian American, Native Hawaiian, and Pacific Islander communities. So I'm so excited to have a wonderful panel today. And before I introduce our terrific presenters today, I want to give a very brief overview of the Asian American Pacific Islander community. This is just giving a very high snapshot of some of the larger population subgroups among this group. But as you know, the API community are diverse groups originating from approximately 52 different Asian countries from the Far East, Southeast Asia, and the Indian subcontinent. There are more than 800 different languages and dialects spoken, and as we will hear later from that, the subgroups within these population are so culturally distinct and have different cultures, traditions, and religions as well. And the API group is currently the fastest growing racial group in the US. The population grew 72% from between 2000 and 2016, and will eventually be the nation's largest immigrant group, surpassing the Latino population by 2055. So we are expected to more than double. And with this tremendous growth comes the need to better understand and address the unique issues facing this diverse community, which is so often invisible and overlooked. So I wanted to share the national breastfeeding trends data just a little bit to kind of set the stage. This is taken from the National Immunization Survey data, and I want to thank my CDC friends for sharing these data with me. So I want to show you how the API breastfeeding rates show up in relation to other ethnic and racial groups in the US. So as you can see, the yellow line is the Native Hawaiian and Asian national breastfeeding rates trends, and where you had initiation at 86.3%, you can see there's a downward trend towards that in 2014. It's been up and down, shows variation, but there's been, 2013 onwards, there's been more of a downward trend. Again, at 6 months by ethnicity, you can see that compared to what 2009 in this kind of aggregate data trends that you see, it's showing a slightly downward trend again. But then again, when you see that clubbed with some of the other races, on an aggregate level, we can look at it and say, well, they seem to be doing pretty well. They're doing better than the non-Hispanic white population or the non-Hispanic Black, and even our Hispanic population. But what's really interesting that you will learn in today's presentation is that really all data is local. And it's so important to know what these data mean within the context of our communities. And often when we see the aggregated national level data, it does not tell the full story of the wide variations and the stark disparities within these population groups. So again, exclusive breastfeeding at 6 months, as you see by race and ethnicity for national level data at where the API community is. And then you can also see the supplementation rates for this community at 2 days is fairly high. So with that, that's just to kind of frame up to show that, we have such a dearth of disaggregated data, and so we really need more data on this community for the fastest growing community, immigrant community in the US. But also today you'll see how local data can be used to really create collaborative partnerships with communities and other stakeholders to transform systems. So I am thrilled to introduce this amazing panel. Tonya Lang has supported breastfeeding families for over 13 years as a La Leche leader in Oakland. Her public health experience includes positions at the CDC and Asian Pacific Partners for Empowerment and Leadership. Currently, Tonya is the co-chair of the Alameda County Breastfeeding Coalition and also the co-chair of the ASAP, the Asian, Southeast Asian and Pacific Islander Task Force. Ms. Lang received her MPH in Health Promotion, Disease Prevention from the George Washington University School of Public Health and Health Services, and she is a certified health education specialist. Welcome, Tonya. Jeanne Kettles is the WIC Regional Breastfeeding Liaison, or RBL, for the Alameda County. She facilitates partnerships, as in her role as the Regional Breastfeeding Liaison. She facilitates partnerships between 7 local WIC agencies, hospitals, community healthcare centers, public health programs, and other community partners to improve access to WIC and quality breastfeeding care for WIC-eligible families. Jeanne served most of her professional career as a midwife and has been a certified lactation educator for over 28 years and an IBCLC since 2016. Jeanne holds a master's in integrative health and applies her experience in integrative team building skills to the development of culturally responsive programs in which mothers and care providers feel empowered to thrive. And we will be doing a spotlight on the Alameda County Breastfeeding Coalition later this in a few weeks, and you will see the range of issues that the partnership between WIC, the coalition, and the other community organizations like La Leche League and many other, that the range of organization activities that is done by this amazing county. Our final presenter is Grace E. Grace is an IBCLC and is the Breastfeeding Coordinator and the Breastfeeding Peer Counselor Program Supervisor for the City and County of San Francisco WIC program. Before she joined WIC in 2009, Grace worked at a public health center and at a hospital outpatient clinic as a health educator, where she worked with mothers and infants from diverse cultures and background. Grace, in her 20+ years in breastfeeding education, support and promotion, Grace says that her tenure at WIC has been and continues to be the most meaningful and galvanizing experience. Grace is also a board member of the California Breastfeeding Coalition, and we are so very fortunate to have Grace's leadership at USBC. Grace serves on USBC's Conference Program Committee and has been for the last 2 years. She's guiding the development of this year's program, and there is not one job that Grace will not volunteer for. She is our rock on the committee, reviewing proposals for awards, reviewing proposals for breakout sessions, and so we are very, very thankful to Grace for all that she does. And with that, I'm going to turn it over to Jeanne.
Thanks, Kinkini. Well, first, we just want to say thank you so much for inviting us to share this work that we've been doing on this USBC Racial Equity Series. And we're really looking forward. We were talking, Tonya, Grace, and I, about having time at the end to really hear from you what's going on so we can learn from each other. So our ASAP, we kind of love that this is a play on words because it's always this kind of what's the fire in the moment? What's the worst situation? And we saw this fire, this smoldering fire of this equity issue grow and grow. And so it kind of covered who we were working with, Asian, Southeast Asian, Pacific Islander. We turned that I upside down and we made an exclamation point and called it ASAP. And this is our mission, to advance breastfeeding equity for Asian, Southeast Asian, and Pacific Islander families in Alameda County through multi-sector collaboration for community and systems change. The task force was originally formed. It was part of the work that I was doing as the regional liaison, and quickly became part of our, as Kenny mentioned, active Alameda County Breastfeeding Coalition, and involves a lot of different partners who we hope to represent in our time with you today.
Okay, and good morning. This is Tonya Lang. Jeanne and I are here in her office together, so we'll be going back and forth for our part of the presentation. We just wanted to quickly go over our agenda for today. First, we're going to look at just a quick overview and demographics of our population. Who are Asian, Southeast Asian, and Pacific Islanders? And then next, we're going to look at cultural practices as well as clinical factors which influence breastfeeding outcomes, such as supplementation of the breastfed infant, and also ethnic Asian risk factors. Next, we'll talk about why we feel we need a breastfeeding equity task force and who is participating with us. Then we'll look at surveillance methods and determination of action areas, resources to support Asian and Pacific Islander breastfeeding families. And we're excited to share with you the successes and challenges of ASAP, such as our new Chinese video translations we contributed to the Global Health Media Project Library, and also just kind of go over next steps. So just a quick overview and demographics. What do we mean when we say API? So the continent of Asia has over 48 countries, including China, Cambodia, India, Indonesia, Japan, North Korea, South Korea, Thailand, Vietnam, and dozens more. So that's just Asia alone. The Pacific Islands cover a geographic region that spans a distance broader than the United States of America, and includes dozens of distinct cultures within Micronesia, Melanesia, and Polynesia. So we just wanted to show this map and also just take a moment to look at how many different cultures and distinct languages are included in this grouping that covers more than half of the globe. One thing we also wanted to note is that the political status of the islands, of each island and region and the countries vary greatly and greatly affect both community approach to care as well as access capacity, whether residents of those islands can actually access services.
This slide depicts the level of linguistic isolation in California by language for Asian, Southeast Asian, and Pacific Islanders. The languages in the leftmost column, underneath the greater than equal to 50%, are in order from the greatest population, so the largest number, to the lowest. In the languages for which greater or equal to 50% or more of the California population are linguistically isolated. For example, for Chinese, over 50% or more of the 500,000 Chinese-speaking Californians are linguistically isolated. So linguistic isolation is a concern for those who speak a non-English language and speak English less than very well. Almost half of those identified as linguistically isolated in California and in Alameda County are Asian, Southeast Asian, and Pacific Islander. Language barriers can negatively impact the quality of care in hospital and clinic settings. And in fact, many of our hospitals report challenges bridging Asian and Indic languages when providing breastfeeding support. Those translation lines don't always work the way we want them to, and the language doesn't always match what we're trying to share with the mothers and families. There's over 100 languages spoken at home in Alameda County, with a relatively high number of Chinese, over about 125,000, Hindi, almost 28,000, Tagalog, over 56,000, excuse me, speakers. And Alameda County has approximately 19% of the population over 5 years old who speak an Asian or Pacific Islander language. And that's twice the rate of California Asian or Pacific Islander speakers, which at the last data was about 9%. Foreign-born mothers account for almost half of all births in Alameda County. And about 82% of Asian infants and about 48% of Pacific Islander infants were born to foreign-born mothers. So one could imagine that language as well as cultural concerns really come up with those families. The top countries that we're looking at for foreign-born are from India, China, Philippines, and Vietnam. So there's Alameda County, for those of you who are wondering where we are. We're in California. I like to say we're in the little heart of California, right there in the Bay Area, across from San Francisco, where people believe they leave their heart, but it's actually in Alameda County. There's about a little over 1,600,000, and it's a very diverse, ethnically diverse, and predominantly urban county, but there's also rural areas as well. Just a little bit of the current birth data for that over 1.6 million residents. There's approximately about 19.5 thousand live births each year. The Asian births are the largest number of births, and that's currently at 31.5%. Even though Pacific Islander, which is at the top of the pie there, is less than 1%, it's actually the highest rate of birth for the population. As I mentioned before, 9,500 are foreign-born mothers. That's 49% of the births. And 45% of the births are also first-time mothers, 8,600. We have a pretty significant amount of families giving birth while on the Medi-Cal insurance. So that's about 26%. And unfortunately, our data shows that greater than 77%, or greater than 14,000, receive less than adequate prenatal care. And that really dials into a lot of factors, including breastfeeding. Alameda County is a core foundational principle in the work that we do in Alameda County Public Health is about equity. So our community assessment, planning and evaluation department, our CAPE unit, really looks at, where are people? We really want to align services with where people are living. And with all the different economic changes, changes in job availability, housing crises, we really are looking at, are we able to serve people locally accessibly? So this is a map about race and ethnic plurality. Race ethnic plurality is defined as that race ethnicity that has the highest population in the census tract, which may or may not be the majority. This map represents the race ethnic plurality at the census tract level for Alameda County 2017 data. The blue areas of the map correspond to Asians. And remember, we talked about that being a lot of different kinds of communities, but Asians by data. The pink is African American Black, green is Hispanic Latino, and yellow to white. So you see that Asians are the plurality in many parts of the county, particularly in central Oakland and South County. And we've really seen a big shift out of central Oakland, where there had been, for generations, a lot of Asian communities moving further south, and a lot of that is due to housing rental prices, as well as job availability. Tonya? Okay, yeah.
Now that we have just this quick snapshot about the diversity in our county, we're going to show just some state and local data that we have. Because we do live in a very diverse state and a very diverse county, we are able to pull local data that is more relevant for our needs. Looking in California, we see that 32.3% of breastfeeding Asian infants in California will be given formula supplementation in the first 2 days of life. So that's a pretty high number, because that's more than 2 times the Healthy People 2020 goal of no more than 14.7%. Also, Alameda County Asian and Pacific Islander mothers have the highest rate of prenatal intention to breastfeed at 95%, which is good. And then you also look at Asian and Pacific Islander mothers also having the highest rate of breastfeeding initiation. So that's 92.7% compared to the county average of 89.8. But within the first month, exclusive breastfeeding rates for Asian and Pacific Islander infants is the lowest of all groups. So we're looking at 39.5% compared to the county average of 50.4%. So even though Asian and Pacific Islander mothers have the highest rate of prenatal intention to breastfeed and also the highest initiation rates, we're looking at very high supplementation rates within the first month. And then when you look out to 3 months, that goes even lower still to 28.2% for exclusive breastfeeding. So, you know, looking at this data, we wanted to know why these mothers who intended to breastfeed were supplementing so early, and how can we support them? So what are the cultural factors, and how did they vary from group to group? And were there structural barriers, including language or geographic access to appropriate care? We needed to find out more, obviously, and the only way to learn this was to gather members of the community to share knowledge and plan how to expand our work in these communities.
And Grace,
Tonya.
Yeah.
Yes.
Hello.
Can I add to the data?
Yes.
About exclusivity rate and also supplementation. Is that okay? All right.
Yes.
This is Grace. I work in San Francisco, and even though California is the leading champion in breastfeeding, however, locally among Asians, the exclusivity rate is lower than white. Asian American, according to 2016 data, 60% for Asian Americans versus white at 89.1%, Hispanic 86.6%, and even African American is higher than Asians. African Americans' exclusivity rate is 73.6%. And then our peer counselor kept record of 142 infant feeding mode. 71 of 142 newborn, 71 of them receive formula at hospital. And then this is the all race and ethnicity group. And then 66 of the 71 newborn who receive some formula at hospital are Asians, are Chinese. So it's at 92% for Chinese babies receiving supplement.
Thank you, Grace. And I was actually going to say that 32.3% is from the California in-hospital breastfeeding data, which, as you may be familiar with, is that's the newborn screening data, which happens in the first 24 hours. We know, and the hospitals admit, that those figures are actually much higher, because by the time they're discharged, especially if there's any concerns like we'll talk about in a moment, that would be higher. And that was, you know, the survey data that you have from the peer counseling database, the survey data that we shared showed that that's actually much higher. So that was definitely a big concern for us.
Yes.
Let's look at some of those factors. Yeah, thank you.
Our work with the communities of families and providers led us to understand that the challenges lay within the intersection of social and medical and cultural factors. So Jeanne's going to talk about some of these clinical factors.
So like we said, we were like investigative reporters. So we were out talking to learn more about why Asian breastfeeding infants were receiving early supplementation at such a disparate rate. We interviewed pediatricians and nurses at some of the delivery hospitals, and they informed us that the increased risk and incidence of elevated bilirubin for Asian infants was the #1 reason. Now, just for those who might be on the line that are not familiar with that clinical indication, severely elevated hyperbilirubinemia is a risk factor for a very serious, irreversible, although rare, thank goodness, condition of bilirubin encephalopathy or connectors. Now, the most recent studies in high-resource countries suggest that in the absence of significant comorbidities such as sepsis or Rh hemolytic disease, connectors occurs in about 1 in 200,000 live births, and only when levels are very high, like 35 milligrams per dilution. So, and Asian ethnicity alone is not directly a risk factor for connectors, but it's considered a major risk factor in combination with other factors. So let's look at the clinical guidance, and this is either informing, or it's not being followed, and so therefore not really informing the care from what we had seen. So we heard from the doctors and nurses that this was an issue. In the Academy of Breastfeeding Medicine Clinical Protocol number 22, this is recently revised, and if you haven't, familiarized yourself with this, I really encourage you to. It's really an excellent document. It's very well written and talks about the different risk factors. The other protocol to which pediatricians will refer is, of course, the American Academy of Pediatrics clinical guidelines. And here is where we see that they identify as a major risk factor East Asian race. And there's, as they describe it within their data review, pretty reliable data that shows an association. But here's the wording that's kind of interesting. East Asian newborns also have a higher risk of jaundice, perhaps related to their ethnic or genetic background. But these factors can be additive with suboptimal intake jaundice and or breast milk jaundice and produce even higher bilirubin levels than would otherwise be seen. And this is a direct quote. When risk factors are identified, it is prudent to seek assistance with breastfeeding in the early hours after birth to ensure optimal breastfeeding management. Mothers may benefit from early instruction about milk expression by hand or pump to protect the milk supply. So we have them actually defining, and this aligns with Academy of Breastfeeding Medicine, defining the intervention. One could argue that it would be better if they actually put in there that stipulate referral to an IBCLC, but they are talking about that early breastfeeding management. So the guidelines are clear to protect breastfeeding. We'll just read a little further. The focus of the guideline is to reduce the incidence of severe hyperbilirubinemia and bilirubin encephalopathy, while minimizing the risks of unintended harm, such as maternal anxiety, decreased breastfeeding, and unnecessary costs and treatment, which I think we can all agree that those describe what happens when a mother's confidence is undermined with early supplementation. And we hear mothers saying very often, oh, I didn't have enough milk, I have to do this. And so there isn't really kind of a clear guidelines as to why they're supplementing, and certainly not enough protocols being implemented to really get the express breast milk as a supplement. So again, this is stipulated all throughout the clinical practice guidelines: promote and support successful breastfeeding, perform a systematic assessment before discharge for the risk, provide early and focused follow-up based on the risk, and then when indicated, you would treat with phototherapy, but it really stipulates that even if breastfed infants receiving phototherapy, supplementation with express breast milk or formula is appropriate if the infant's intake seems inadequate, weight loss is excessive, or infant seems dehydrated. So really the formula is only to come into play if there's other compounding factors. So you have a breastfed infant, maybe at risk, looking at this bilirubin before you discharge. The protocol management should be get the mother expressing her colostrum, getting her milk supply going, and only in the situation where a compounding factor of excessive weight loss or dehydration would one consider formula. So it's all there.
So those were just a quick review of the clinical practice guidelines. We also looked at what all is out there in terms of patient education. So what we found was the American Academy of Pediatrics has patient education brochures which physicians can purchase to hand to their families. However, the literacy level is very high to begin with, and even though East Asian ethnicity is clearly identified as a high risk factor, the brochure is only available in English or Spanish, so it has not been translated to Asian or Pacific Islander languages. So next we're going to talk about cultural factors. So I'm going to hand that over to Grace Yee, who can talk a little bit more about those things.
Thank you. Thank you, Tonya. Before I talk about the cultural factors, I want to share a story with all of you. May started fully breastfeeding her newborn. However, at day 3, the mother-in-law intervened. She suggested May to supplement to add formula after each feed. So May obeyed, and she did accordingly. In 2 days, which is 5 days after the birth, the baby started having projectile vomiting. So they rushed the baby to ER, and that the baby need to be kept overnight for observation. Fortunately, the baby was discharged the next day. However, upon discharge, the doctor warned Mei Mei, stop supplementing formula. Stay with breastfeeding because your baby has been overfed. The reason is because she added 4 ounces of formula after each feed. So poor baby. What does Mei Mei's story tell us? Cultural belief, customs, practices, or under the influence of modernization and immigration, all of these have far-reach effect on breastfeeding in Chinese families as well as in Vietnamese families. I'm going to focus on Chinese and Vietnamese because that's my background. Next slide, please. Influences on breastfeeding in Chinese families, cultural postpartum practices. All Chinese mothers are expected to observe the first month's confinement, which is also called 坐月子 in Mandarin. It literally translates into sit the month, in other words, confined. And it's widely believed that the mother has lost a lot of her blood and a lot of her heat. And so it created an imbalance. And therefore, the mom needs to observe certain practices to regain her strength and restore her balance, and also to protect her health in old age. Even though there is a little bit difference among different groups of Chinese and Vietnamese, there are common 坐月子 practices, which would include eat certain food while avoiding other foods. All the mothers are expected to stay indoors and focus on getting a lot of rest, especially in bed. And she's also tried to avoid over strenuous activity. And she's not allowed to go out, only necessary. And she's also encouraged to avoid contact with water or wind. And if she needs to take a bath, she should bathe in hot water boiled with ginger. Okay, next slide, please. And food is a very, very important element in the Chinese postpartum diet. They focus on restoring the heat and the blood, and therefore they use a lot of chicken, a lot of ginger, a lot of fish. Some of this food are actually believed to be lacto to be able to bring in milk. And the most common dishes are chicken soup with red beans, chicken soup with ginger, chicken soup with wine, and papaya fish soup. Next slide, please. Thank you. And then breastfeeding in Chinese families, there are a lot of factors playing into influence. Traditionally, the grandmother of either the maternal or the paternal grandmother or other female family members or higher helpers, they would provide postpartum care for the mother and their babies. And nowadays, if they can afford it, Chinese new mothers may hire postpartum helper or doula, or they may check into a postpartum center, postpartum care center, or they would order first month confinement meals to be delivered to her home every day. All these practices are good. However, by using a postpartum helper or using the grandmother as a helper, they may shift the responsibility of infant feeding from the mom to the helpers. And a lot of times they would fall on using formula. They would rely on formula for infant feeding. Implication on breastfeeding, grandmother may take over feeding the baby, and workers at postpartum care focus on taking care of the mom, providing the mom with plenty of rest, and therefore they would take over feeding infant with formula. Next slide, please. Now let's talk about Vietnamese families. Similar to their Chinese neighbors, Vietnamese mothers are considered to be vulnerable to the element, and therefore they would usually stick cotton balls into their ears to keep the wind from blowing into her head. And during the first month of confinement, a new Vietnamese mother are taken care by her family, and they are discouraged to go out or exert herself, and sex is also discouraged, similar to the Chinese belief. Next slide, please. Thank you. And breastfeeding in Vietnamese families, Vietnamese practices on breastfeeding is that Vietnamese women put warm towel on their breasts to warm up their milk, so that to make sure that the baby doesn't receive cold milk, and therefore the baby would not easily get stomach pain. Most of them would discard the colostrum because of the yellowish color. They think that it's dirty. And the practice is to keep the new mother and the newborn warm. And some mothers would actually add formula or other foods for additional nutrition, especially at the 4th or 5th month of the baby's birth. Common Vietnamese postpartum to bring in milk would include banana stems and pig's trotter and papaya soup. Next slide, please. Thank you. Influence from families, both for the Vietnamese and the Chinese mothers. Postpartum practices belong to the female domain. The grandmother helps care for the newborn and oversee the provision of the new mother's postpartum meals. The grandmother also has a significant authority on infant feeding choices. Thank you. Next slide, please. And other influences on breastfeeding. A news article published by a Hong Kong newspaper in February 2016, the author attributed Hong Kong mothers' low breastfeeding rate at 2% to 4 factors. Number 1 is unmonitored marketing of infant formula. Number 2, lactation space lacking in quantity and quality. Number 3, lack of breastfeeding education. Number 4, insufficient support for lactating mothers at their workplace. All these sound so true for San Francisco and the Greater Bay Area, as well as the whole nation. And the other factor is perceived values of infant formula. Some Vietnamese families think that infant formula would provide 2 desirable qualities for the infant's development: intelligence and body height. By adding formula and other complementary food to the baby's diet are believed to enhance the baby's growth. A study in Fujian province in China cited reasons for early supplementation with infant formula would be concerned that the baby may not be receiving proper and adequate nutrition. Employment is another reason for early supplementation at 2 to 4 months in Vietnam. And then separation of mothers and babies, postpartum confinement, when the grandmother or helper take care for the newborn. And then long work hours. And the other common practice among new immigrants from China, Chinese parents, because of lack of family support here, and also for long work hours, Chinese parents may send their babies home to their parents, to their grandparents, to take care of them. And so that explains how come they don't want to start breastfeeding, and they may not be able to continue breastfeeding once the baby is taken away from them. And these babies are called satellite babies. And then healthcare providers' assumption that Chinese mothers do not, or Chinese or Asian or Vietnamese mothers don't want to breastfeed, and therefore they would offer them formula. This is a very common practice in some of the hospitals that serve a lot of Chinese population. Next slide, please. Thank you. How do we support breastfeeding? we can build on the strength of the Chinese and Vietnamese cultural practices, include the father and the grandmothers in the conversation of breastfeeding in their prenatal education, on infant feeding plan, and also postpartum breastfeeding support. Postpartum confinement allows the mom to eat and focus on breastfeeding. Family members can take care of the mom, and mom feeds the baby. Grandmother helps with cooking and housework, but let the mom feed their baby. Prepare the mother to breastfeed and provide immediate postpartum support using the peer counselors. And then establish a referral system for appropriate lactation care. And we also need to work with the communities, educate employers on the provision of lactation accommodation, collaborate with and support physicians and health clinics to promote breastfeeding. And that regional breastfeeding liaison really comes into place. Next slide, please. So what strategy do we have in San Francisco? We engage the community groups. We collaborate with them to support hospitals, health clinics, childcare providers, and employers as well to promote breastfeeding. One of the prime examples would include Healthy Mothers Workplace Coalition, which we work together. We involve hospital, healthcare, clinics, employers, HR, local politicians, and the health department. And out of that, we created San Francisco Lactation Ordinance, which I will talk about in the following slides. And then the other group that we work so well with is the Peninsula Regional Breastfeeding Collaborative, which includes San Francisco, San Mateo, and Santa Clara, because we serve the same diverse cultures. We work together to apply for the RBL program. And then the other big organization that we work with is the Northeast Medical Services. It's a healthcare organization that's similar to Kaiser, except it doesn't have the hospital facility. And they serve primarily Chinese and Asians. And then we also work together with Children's Council and other childcare providers. Next slide, please. Oh, no, that's it. That's all I have. Thank you.
Great. So a little bit about the task force, kind of how it came to be. I know everyone always wonders how you just make these task force happen. Just a little bit of how it evolved and who's involved and what we do. So the common ally in almost all of the current breastfeeding programs is WIC, the Women, Infants, and Children program. For Asian families, over 5,000 infants are born to Asian families each year in Alameda County, and over 27%, or over 1,500 of these mothers are enrolled in WIC during their pregnancy. And we were really finding out that that was pretty much the only way that they were going to get breastfeeding education before their babies were born. So what is WIC? WIC is a federally funded health and nutrition program for women, infants, and children. Participants must meet income guidelines and be pregnant or new mothers, infants, or children under 5. WIC offers quality personalized nutrition education and vouchers for supplemental food, prenatal and postpartum education on infant feeding and baby behavior, and breastfeeding peer counselors and lactation consultants. So even for those bottle-fed infants, WIC offers education about paced bottle feeding, lots of things about returning to work or school, making a pumping plan. So lots of personalized education and support, and as Grace mentioned, peer counseling programs as well. The WIC Regional Breastfeeding Liaison, or the RBL program you've heard mentioned, and that's what I do. In Alameda County, I represent 7 WIC local agencies, And my charge is to strengthen the continuum of breastfeeding care for WIC-eligible families and communities. So RBLs work with the hospitals and community healthcare centers, physicians, nurses, care providers, and community public health programs, lots of folks. So what I did was reach out first to a couple of the established Asian community groups and Asian advisory boards to share information about breastfeeding and WIC services. And most were greatly surprised to learn of the ways that WIC foods and services actually support Asian and Pacific Islander families, and how mothers were eligible, how many mothers were eligible for WIC. There are, milk and cheese and other foods that might not be in the diets that you saw Grace share pictures of, but there are other things that WIC offers, like soy products and vegetable farmers market coupons, lots of other things with beans and things that they can integrate that can help stretch their budget. And then we do have many peer counselors that actually can work and speak in the language, which it was really nice to bring from the different WIC agencies that I represent, to bring them as a panel to some of these boards and to hear directly from them the cultural practices. It really built a lot of familiarity and sense of how WIC works with the families in a culturally aligned way, and what were some of the resources at WIC. I do want to share that, like I said, Alameda County works, really focused on equity. Prior to this work, there was an initiative within the Alameda County Public Health Department Perinatal Services, and they were awarded funding to address the unique needs of Pacific Islander communities. And their specialized program, the Health Advancement for Pacific Islanders, or HAPPY, they were able to hire outreach workers, like the picture you see there is Malika Finaki. She's awesome, and she's from the community, and she assists with culturally appropriate programming and outreach. One of the key targets of this initiative was to have moms earlier into prenatal care, because that was a big disparity for Pacific Islander families. They were coming in late for care, perhaps missing a lot of screening and testing, and also opportunity for education. So the HAPPY program has been able to connect families with a multitude of services, and the fathers and the family members as well, but that includes breastfeeding support with WIC. And the HAPPY initiative is connected to a larger tri-county task force that includes San Francisco, Alameda, and San Mateo. And they are working collaboratively with public health and community leadership to raise awareness of Pacific Islander assets and needs, and align county agency efforts in data collection and access to healthcare that's appropriate. And this regional initiative is led by some really incredible women. Up in the upper left-hand corner, you see Talve and Leafa and Martha and Natalie, and over on the right-hand side, you see some of our perinatal services coordinators in the picture with them, Teresa McCluskey and Carla, and just really terrific teamwork. These pictures show some of the ways that the task force engaged communication with the community leaders and shared their cultural values: family, God, enjoyment of life, sense of fun, and land identification. I really learned a lot from what they shared, just from all of what are the different island cultures and how distinct and wonderful they are. Also, church community is a very significant factor in the leadership. And even though this initiative started before ASAP, when they were aware of what we were doing, we were eagerly invited to come participate, and vice versa. They came and presented to the ASAP task force, and we came, and any way that we could help out. If breastfeeding, they had a lot of other concerns like housing and many other access issues, but they knew that we were there to support the moms in any way that we can. I wanted to share a few little takeaways that they shared with us about things to consider when working with Pacific Islander families. They're good listeners, but they delay making on-the-spot immediate decisions. And building relationships is very important. So asking for some sort of immediate or quick response, no matter how urgent it may seem to you, can really delay or affect a positive outcome. So many of those kinds of behaviors are perceived as aggressive, in philosophy and tone and demeanor, and that's threatening and considered impolite and disrespectful. So easy does it. And follow-up is a must, and it is a practice that shows that you care. And I really found these statements to be so true. So just letting them know that we were there, listening to what their concerns were, really learning, and just really continuing to show up and follow up, really built for me some really wonderful relationships with the leaders of the Pacific Islander Task Force and community.
All right, so after gathering information about cultural traditions and best practices from some of the key informants that are implementing successful programs, we decided to formally invite an expanded circle of partners to a talk and tea to share what we knew and question what we needed to do and how. So our talk and tea was held in August of 2016, and you see just a sampling of the agencies and the groups that came together with us at the talk and tea. Together we looked at the data and we shared our perceptions of underlying factors and barriers the families and their communities of care may face. So we talked about everything from linguistic isolation, lack of educational resources, lactation accommodation challenges, and much more. So from that, we worked towards determining action areas. So we took the ideas from the group discussions and organized them into themes. So you see kind of like our pictures of the big sticky walls, organized all of our ideas into themes for action, which we'll share in a moment. The next step was to take these themes back to the larger Alameda County Breastfeeding Coalition, just to get their insights into how we could work in these areas to make effective change. So there is some overlap between the two groups, but we wanted to kind of check back with the larger coalition just to see if they had any other ideas on how we can move forward.
So one of the areas was we really needed to hear from the voices of the family. So how could we better engage the communities? To gather some more information, again, we really try to have some data. We asked WIC, the different WIC agencies, if they would be willing to administer a modified PRAM survey, so the Pregnancy Risk Assessment Monitoring Survey, and we hoped to get 100. We wanted to get a good sampling size, even though the WIC sites were really helpful and the moms were really great, because we didn't offer them a stipend or anything. It was just sort of like, would you be willing to answer a few questions to help us improve breastfeeding services? We were only able to get 54 WIC mothers surveyed, but we still learned quite a bit from the results, including significant gaps in prenatal breastfeeding education and the medical practices at which the families received care. So we really got it very clearly that if it wasn't for WIC, they were probably not going to get a whole lot of basic messaging or access to classes or mother-to-mother support groups. We also wanted to strengthen our inclusion and targeted work with the Indian population, which is a growing population in Alameda County. And we've been welcomed by a pediatric medical group of Indian pediatricians who work predominantly with the community in South County. And guess what? They are big breastfeeding advocates. So we were excited about that, and that's our forward work.
So our next theme was culturally appropriate education. So what we did was we compiled an extensive resource listing of breastfeeding education materials, posters, and more that were in language, that included Asian languages, and made these available to all the clinics and community resource programs. We also collaborated with the Global Health Media Project to work on Chinese translations for their breastfeeding videos, because they offered the videos in many, many languages, but guess what? They weren't in Chinese. We're very excited about that. This was a very challenging project, and we made slow progress, but we do have 2 videos translated, and we'll show you that in a moment.
So as mentioned before, many providers assume that the differences in supplementation practices were culturally mediated, including issues with family members pressuring mothers to supplement. And there may be some of that, as Grace was sharing in her one of her case studies, but we had to engage physicians to consider their clinical responses to elevated bilirubin risk factor for ethnic Asian and jaundice. And so the challenge to supplementing with formula instead of express breast milk and giving them that education, showing them the guidelines was really eye-opening for them. And I will say, to their credit, almost all providers were very receptive to the shift in practice once it was explained to them how expressing breast milk would be more effective at achieving the health goals. And some were so excited to immediately make such a simple and significant shift. It was brilliant. And they appreciated ASAP's work to provide materials to assist with patient education because they didn't have anything. So we also work with Alameda Alliance, our Medi-Cal Managed Care Plan, who, by the way, does an excellent job with breastfeeding promotion services and education. They have home visiting lactation consultants as part of their benefits for members. They share their utilization data, and we identified over 50 physicians who worked with Asian, Southeast Asian, Pacific Islander families. We had a phenomenal partnership with Asian Health Services, and they serve a great majority of Asian families, and they promote their targeted education to their providers. Tweet Kwan, who I wish was on the call with us today, she's the Asian Health Services Perinatal Services Coordinator, and Victoria Xu, who's the community health worker, were the leads on the first 2 translated videos, and that's Victoria's voice you're going to hear. And then our next step is going to be a webinar for supplementation of the breastfed infant, which will highlight the link between health equity and clinical practice. And our goal will be that at least 75% of the healthcare providers participating in the training will report a change in practice with breastfeeding support and/or referral. We really want to strengthen the quality and availability of prenatal education in the healthcare practices, or at the very least, improve referral to WIC culturally appropriate services.
So in the area, our next priority area of lactation accommodation, what we did was we printed and distributed thousands of the WIC breastfeeding and the law cards, these little like business-sized cards, and in 4 Asian languages. So we translated them in Chinese, Vietnamese, Hmong, and Korean, and distributed them at many events and clinic sites. So our next step in this area will be targeted outreach to chambers of commerce. So, we focused on educating families first, and now we're looking at educating businesses. And Grace also has something to add about her work in San Francisco.
Thank you. In San Francisco, thanks to the supervisor, Katie Tang, she initiated the lactation in workplace ordinance. It got passed last year, in May last year, and it became operative this year in January. And this law strengthened the existing California law, and the ordinance requires San Francisco employers to have a policy regarding lactation in the workplace, and this policy should specify a process by which the employee can request lactation accommodation. And this ordinance also defines minimum standard of lactation space, and also requires newly constructed or renovated buildings to include lactation spaces. Finally, this ordinance includes a requirement that San Francisco Department of Public Health to provide a set of lactation accommodation best practices and a model policy for businesses, and also include a model lactation accommodation request form. And this is really good. However, no matter how breastfeeding friendly this ordinance is, it has not been translated into different languages. Some of the publication that is developed by Legal Aid, which is a big partner on this ordinance, Legal Aid at Work, they have publications in English, Spanish, and Chinese, but none in other Asian languages. Thank you.
And our last goal area that ASAP identified was a public information campaign. So first, we obtained permission for many media images and continue to advocate for more representation of Asian mothers and infants in breastfeeding promotion. And then we'll use the results from the survey to use some of the key messages from the mothers to create posters to distribute in our promotion efforts and at our Breastfeeding Awareness Month celebration this month. Wanted to also mention that workforce development remains an area of interest and concern.
So here in Alameda County, we have only 2 breastfeeding peer counselors who are of Asian descent, and a very limited number of Asian or Pacific Islander lactation consultants in the area. Although there are staff from local clinics and WIC sites that would pursue IBCLC credential with financial and management support. So, so we're lacking in representation for IBCLCs, but there is an interest among the local clinics and WIC sites. And going back to our task force, you know, in conversations with the task force, there are members of ASAP who are IBCLC and who have offered to assist with mentorship opportunities. So we're hoping to kind of connect everyone just to address the issue of workforce development. We also hope that our work will increase the cultural awareness and capacity to support breastfeeding Asian and Pacific Islander families with all of our community partners and practitioners with whom we work. And Grace, do you want to talk about San Francisco?
Yes, I will. Thank you. In San Francisco, all the birth hospitals, breastfeeding support services are provided through to monolingual clients, Asian patients. They provide this by through interpreter services. And then at the Northeast Medical Services, which is I mentioned before, is a major healthcare organization, community-based organization that serves a large number of Asian and Chinese women. This whole organization doesn't have a single CLE or IBCLC. And so they rely a lot on WIC to provide lactation support. In the MCH division in San Francisco, there are 6 public health nurses that make home visits. They are also IBCLC. Only one of them is Chinese Chinese English bilingual, and she's also a Chinese descent. At San Francisco WIC, there's 1 IBCLC who speaks Chinese and Vietnamese, 1 peer counselor who speaks multiple Chinese dialects. And we also have 4 CLE who are fluent in Chinese. There's really a need to develop IBCLC for the diverse Asian communities.
Yes, definitely.
All right, thanks, Grace. So we're just going to quickly go through some of our successes and challenges. So we had a busy first year of organizing and goal setting, and before we knew it, it was time to celebrate and share our success and challenges with our team. So some of our biggest successes included engagement of both mothers and providers in assessing gaps in care and clarifying learning needs, the translation of the Global Health Media Project videos most relevant to the issues the mothers identified in the survey, which was the 2 videos are Is Your Baby Getting Enough? And also Increasing Supply. And our biggest successes were also our biggest challenges. So the survey of mothers, they're relatively short, was still a challenge to administer in a busy clinic setting. And we were only able to get 54, like we said earlier, and our goal was 100 or more. Translation and recording of the videos was just way more complicated, not just technically, but also time-wise. We also had changes in staff, and everyone was doing this on volunteer time on top of their other responsibilities. So after evaluating the first written translation, it was also clear that we had to rework the translation to better reflect how native speakers actually talk about breastfeeding.
So a little bit about the survey that we'd like to share. Almost all of the 54 participants in the survey had breastfed for at least some time. So within the first week of life, 50% of mothers had supplemented their breastfed infant in the first week. Almost all of these mothers said it was because they did not have enough milk. More than 1/3 of the mothers reported that their baby did not latch well and that they were in pain, so offered the supplement for relief. And no mother reported influence by family as a reason they did not breastfeed. And we did ask it different ways so that it wouldn't feel confrontational or anything else like that. But less than 7% reported that language was a challenge. It was a little bit higher with the hospitals, a little bit less with the providers' offices. So that does kind of reflect a little bit what our hospitals were sharing with us. Again, we used the pregnancy risk assessment monitoring system and added questions about family and social factors for that, so we could render some quantitative and qualitative data. The most important thing that mothers reported, they heard about breastfeeding, is what you see on the screen. 63% said breast milk is the best for the health of the baby and their immunity. 22% said specific technical advice was what really was most important to them. 19% information on frequency and feeding and supply, nutrients in breast milk, and then bonding and special relationships. These were the top ones for moms.
Right. And, you know, taking those survey results, you know, we saw that, you know, just some common themes that we thought would be helpful in terms of messaging to Asian and Pacific Islander mothers. So really promoting the benefits of breast milk, nutrients and immunities for the baby's health. Also working with mothers to help them access education and support both prenatally and immediately postpartum. Providing information and guidance on effective latch and positioning, and also really encourage mothers to build their milk supply by breastfeeding early and frequently and understand how to express their milk. So we also had a question on the survey, what would they tell another mother? So you can see some of their quotes. It can be difficult at first, but don't give up, keep pushing yourself, it's the best. Feed or express your milk frequently to make enough milk. You know, so you can see these common themes, and, you know, we would recommend kind of emphasizing those themes as well in your work with moms.
So just to kind of summarize, the intersection of the maternal concern for not enough milk, which, you know, can be then by word of mouth or experience or things, with the provider concern for clinical management of the at-risk breastfeeding infant with potentially elevated bilirubin, and then challenges to protective cultural practices like what Grace was describing, that laying in, well, if they have to go back to work, or if they don't have family nearby, or if there's barriers to language to be able to engage the grandmothers and fathers and others in these practices that support breastfeeding, they raise the importance of promoting knowledge and skills for stimulating milk supply in the first hours of life. So many of these early exclusivity and frequency, skin to skin, limiting pacifier use, hand expression, and access to skilled support. And I know it was suggested that if there are those services, like working with the doulas, working with the confinement centers to try to maybe help them understand some of these practices and what's important.
So I think this is really kind of a long way for us to say we need to have culturally responsive care. So culturally responsive care is defined as care tailored to sociocultural characteristics of a particular patient or group. So it may involve knowledge of cultural traditions, appropriate interpretation of behavior, communication or other skills, attitude, and actual interventions. So when we talk about culturally responsive care and implementing that, that really starts with self-awareness. So the self-awareness on the provider's part. You cannot provide culturally responsive care without first acknowledging your own values and beliefs and communication style. So once we do that exercises with self-awareness, you know, we can look at the factors that contribute to cross-cultural communication. And so we have some of those listed there, like concepts of health. You know, different cultures have different concepts of health, and language and nonverbal communication. That also varies by culture. Grace talked a lot about food practices and how mom and baby are cared for postpartum, how breastfeeding may be viewed, practices that may hinder and support breastfeeding within a culture, and also trying to figure out what kind of counseling strategies you can use that will align with cultural practices.
We're just going to briefly share with you some of the resources, because we really do want to leave time at the end to hear from you what's been going on with you guys. This is just a sample of the compendium that we put together. There's over 50 different resources, but we're going to have to send that to you later because some of the links have been changed, and so we're in the process of updating this. I know Grace has some nice resources here that will be hot links in the PDF that you receive for some of the different cultural things to share. I wonder if we could show you just a minute or two, just a little bit of the video. Oops, what happened? That's us. Hang on one second. I'm going to see if I can bring it up a different way. If you're not familiar with the Global Health Media videos, I strongly encourage you, please go check them out, because They're beautiful. They're very well done. Excellent clinical information, but all in a very mother-baby centered, just beautifully multicultural and great quality. So I'm going to pause it there and bring us back because we have a lot to still cover. Where are we? PowerPoint? Right there. Oh yeah. Oh yeah. Sorry about that. And then the big one. Okay. There's, whoops. I gotta go all the way through. Hold on. We're gonna do it fast.
All right.
Don't get dizzy. Don't get
dizzy. The reason why we worked on a Chinese translation for of the Global Health Media Project videos was just in response to the high level of linguistically isolated Chinese families, and I specify that's Cantonese Chinese, so we're responding to the high level of linguistically isolated Chinese families and the key concerns identified in the survey.
And also, those videos are already translated in Vietnamese and many other languages. It was just Chinese was missing, and that's such a large number. So we'll continue to bring our work and resources to forums like here we are at the California Breastfeeding Summit in 2017, and this wonderful national webinar on equity. Thank you so much. And we hope you will consider the Alameda County ASAP Task Force and WIC your partners in breastfeeding equity for Asian, Southeast Asian, and Pacific Islander families in your community. And so now we're at the fun part, which is we want to hear from you. How are you collaborating with Asian, Southeast Asian, and or Pacific Islander families to promote breastfeeding?
Great. Thank you so much, Tonya, Grace, and Jeanne. What a phenomenal presentation. So yes, please share us, chat us your what you are doing. We'd love to hear more. And also feel free, if you can use the raise hand function, we can unmute your lines as well. So I'm checking to see. Yeah.
There. We do have our references and our contact information that you will receive if you do want to follow up on any of this information or to contact us directly.
And we have a lot of comments saying, just kudos to the presentation and just how packed, but how, invaluable this has been to learn about a community that that we interface with in many of our hospitals, but we don't get to know much about. So do send us your thoughts. As we are waiting for that, I wanted to share too that as a member of the Asian American community, as an Asian Indian, I realized that having worked all my working life in pediatrics or in maternal and child health, but just how isolating it was during the birthing experience. I gave birth in Berkeley in a really terrific hospital, but just when your baby is preterm or the elevated bilirubin levels, just the pressure to supplement is so intense, and I could not have done without. I actually had my WIC family for many years. I worked at the Morrisania WIC program in the Bronx, and I actually used to call my WIC friends, and they were the support that I got all the way from California because I did not have much local support. And I realized one of the things that I realized was for many Asian American families who were not on WIC, I would just keep passing on the WIC educational materials because that's the only place they got anything. If you weren't on WIC, you weren't pretty much getting anything from your hospital, culturally relevant information or materials. So WIC was a lifesaver in so many ways.
Yeah, thank you for sharing that. I do agree when you look at the wording of the AAP and they talk about, don't cause distress in the mother or anything that will affect this. I'm really excited about our plans to have a forum on supplementation of the breastfed infant and the jaundice and this kind of these intersections, because I think it is when you look at what the reality, and yes, it's a horrible thing that people want to prevent, but what is the potential relative risk, and what are the first level of support that you should be doing, and how do you do it in a way that is actually very encouraging? I mean, when a mother is anxious and stressed, it's not exactly best for her flow, so there's a lot of things that are really important to stress with that. I will say one thing I'll just throw out to the group. We took a kind of an unorthodox approach in keeping, we talk about aggregated data and disaggregated data, and people bemoan the fact that it's just so hard to get disaggregated data because they quote unquote don't justify the population numbers to be able to pay for those services to render that data, or the N is not significant enough to make it statistically valid. And those may all be very valid concerns, but we kind of, rather than just say, well, we're just going to focus on one or the other, we say, well, let's try to use it to our advantage. Let's take this number, which, as you can see from the data we presented, is significant enough, and we'll have to kind of focus within the different members to support each other to have these outcomes and things, and we'll learn from each other. And so that was kind of interesting, because I know that there was a lot of historic, like for Pacific Islanders, and I'm really glad that they had their individual task force and focus, because even within Pacific Islander, there's so many different cultures. But I've just noticed in doing this work how there are sort of marginalizations within, if you will, API. So it's been really kind of empowering and interesting and educating work to bring everyone together, even though it is challenging. Like, we're always looking and say, okay, who's not at the table, or there's only so much that we can do at once, but we have that intention and we're very transparent about it. And I think it has been working for us. I don't know that again, is an approach that other people take. They kind of more kind of disaggregate their efforts.
Thank you for that. And it's so true that start with what you have. So we have quite a few questions here about data and saying this is really interesting. And do you mind sharing how did you get some of this granular data, and what's your go-to data source for the in-hospital figures for early breastfeeding facilitation and newborn feeding? So I think not every state has a MIHA, I guess. So do you want to share about that?
Yes, definitely. I love the MIHA data and what the California Department of Public Health is doing with the MIHA data now. They really invested in looking at the maternal infant health assessment. That's what MIHA stands for, and you could Google it. And there's a lot of different indicators, such as income and education and all kinds of health behaviors and insurance rates, race, ethnicity. So they can really cross-cut it on a lot of ways. The questions include the intention to breastfeed, the initiation, the first month, and the 3 months. I think there's even other data points. But it's a massive survey that goes out, and it's a big effort on the state's part. But then we do have really great data to which we can refer, some of the only duration data that we have and intention data that we have. And that is because of the significant size of the survey that we were able to extrapolate for that. As I mentioned before, the in-hospital data, that comes from the newborn screening, which is done within the first 24, no later than 48 hours. And that's, again, we know that the number's higher. So whatever that number is, as stunning as it is, we know that the number's higher as far as the supplementation of the breastfed infant in the first 2 days. And then I think some of the other data that we shared, as I said, Alameda County Public Health Department does a great job looking at plurality and birth rates. We really want to look at what our families need. And so that foreign born and all of those things that you have, that comes from our Alameda County Public Health data work. And then again, our survey data.
Right, thank you. One of the questions is that you mentioned that there would be, that the ASAP task force would be organizing a webinar. Is that only for Alameda County residents or California practitioners, or is that open to all?
No, that will definitely be open.
Wonderful. Questions here about just again, would some of these resources be posted? Yes. We will be, you saw the list of references that are there, as well as some of the resource guide that Jeanne and Tonya mentioned. Some of those links need to be updated because the pages have changed, but we will be posting that in the coming weeks. Will that, lots of comments about the global health media videos are awesome, and I will use them for my classes and refer folks to them. So I think we can, Vinay, are you able to post a link to the global health media if you can? Okay.
Yes, and just to let folks know that the two videos that we have translated, and we intend to have others, are not yet posted because I think I showed you in the beginning, it needs the Chinese characters underneath it in the title. So once we do that and then give that to them, they will post it. And then that's kind of exciting because then that's going to be available worldwide. So I'm really excited about that opportunity. So and we have those first two, and we're plugging away at getting the other ones done with all our staffing changes and stuff. But that's our intention. So yes, they should be posted soon. But for right now, if you go to Global Health Media, you will still see the excellent videos, and we use them all the time. And you'll see in many different languages, but our Chinese one is not yet on that library yet.
Fabulous. And they are all free to download. You just need to set up an account, as Maria says. So thank you for that.
And you can download them in all different formats for your iPad, for your computer, Mac, Windows. It's really well done.
Terrific. And then, immediate future plans of ASAP, how can that, would you be willing to share what's coming down the horizon for some of your other groups as well?
For some of the other API groups within ASAP? Is that what you're talking about?
Either API groups or your own action plans, like what are some?
Yeah, absolutely. One thing, like we had mentioned, we want to translate the whole suite of breastfeeding videos on Global Health Media Project. So we're, again, plugging away at that. That's been a challenge because of, I think we mentioned, just looking at a written translation and really reworking it even to make it more conversational Chinese. And then also the posting of the video, what's spoken, matching that up with the video and things like that. So we'd like to finish up the suite of breastfeeding videos on Global Health Media Project. Oh, yes. And we're also doing more outreach with the Southeast Asian community, the Indian community. Jeanne had mentioned earlier that, we have started working with a group of Indian physicians in South County, where most of the Indian population is located. So that's kind of in progress. Again, we focused a lot of our presentation on kind of East Asian, Chinese, Vietnamese, and Pacific Islander, but that doesn't mean that we're not working on some targeted outreach to other communities, because that's the whole point of ASAP. So we're reaching out to the Asian Indian community. We had talked about earlier, Jeanne mentioned we'd like to do the webinar for physicians on supplementation. In terms of lactation accommodation, we'd like to reach out to businesses and business groups, chambers of commerce, just to try and address lactation accommodations with employers.
So one of the thoughts was, a lot of the moms are working in either nail salons, restaurants. There are the traditional office spaces, but there's also these that have you can't just drop a lactation policy into any forum, right? There's things that you have to look for and accommodate. So we plan to use the Office of Women's Health supporting nursing mothers at work to try to do some targeted in-services with different commerce groups. So that was something that was suggested to us. And I think in general, the public information, like when we have the Global Health Media Project videos posted, we want to work within our partnerships to have, for the local media, we identify different newsletters within different communities and work within our, our key membership to put articles in those languages and put them to let them know that the videos are there, and also promote breastfeeding messages to let them know that. So we do want to figure out within our public information campaign how we can align with the resources, but it's tricky because I wonder who reads the paper. Maybe some of the older generation would, and maybe that would be a good targeted. So I think we need to do a little bit more research to find out. Kenny, you had mentioned the social media campaign. I would really love to take some of the images and take some of the information from the survey of mothers and kind of just do something like that, like the blast with that.
Absolutely. And thank you for that. And just to, this is just really such a one-of-a-kind task force, because we don't know of any other state that is doing it. So if you are, please let us know. But also the fact that so much of this is being done by volunteers and is being done over and above people's day jobs, and that the coalition is kind of the fulcrum for all of these many different partnerships that are happening too. So amazing work. We have a few questions asking if you would be willing to share the mother's survey or just some of your meeting design kind of questions when you first convene these community groups and with community engagement. What were some of those templates and things? Would that be something ASAP would be willing to share?
Sure. I mean, we literally took the PRAMs, because that's a national survey. We looked at New York and Texas. I think they had there's a certain standard set of questions around breastfeeding, and then there's variations from state to state. California doesn't process the PRAMs because we focus on the NEHA, but we took some of the states that we knew were very forward in their breastfeeding initiatives. We used their wording, and then we literally just added a couple on some of the multiple choices to include family and social factors and language factors, because that surprisingly was missing. So
that's good to know. So there was very little that you had to customize some of those. So the bulk of the questions were based on the PRAMs. I see.
Right. Yeah. So yeah, we're happy to share that, because it's our own. I mean, it's just taxpayers' stuff, right? It belongs to everybody, the PRAMs, and we just added a few questions. So we have no problem sharing that. And there's a lot of other information we couldn't share it all today because we were trying to talk about how the task force worked and came about. But there's, not really kind of like, we have our data, and then we gleaned from it some of these themes and things, but which I think we shared with you the majority of that key points. But I'm happy to share the survey if people want to implement it to, get their own data.
Right.
And then the interviews with the physicians were really built upon the relationships that I have in working in the different groups around breastfeeding quality improvement in the hospitals. And I would just, directly ask them. So it wasn't formatted as one would with like an interview, like I'm going to ask the same questions of every physician. It was really much more about conversations and interactions and what are you seeing? How do you see it? Like just really open-ended questions, and then delivering that information about what the guidelines are. So that was really that process.
Really, and so true that the takeaway is that those connections and trust and relationships are so important. So even if one is not planning a big venture, whether it's, for coalitions to be working with hospitals, with community members, with community leaders, so that they're primed to be doing this work. And as we said, with this, rapidly growing community, we really need to do much, much more than has been done to support. So thank you again to our fabulous panelists. We will continue posting the resources relevant to Asian American, Native, and Pacific Islander population groups. And also, we will send out an email via the learning community when some new resources have been posted as well. And please, for those who are participating today, if you have some more, please send. We know that, just because of the volume of work that's happening in California, we have Yang Her from the Community Resource Project WIC in Sacramento, who's done amazing work with the Hmong community and has a lot of culturally relevant information there as well. So we will also, the USBC staff team will try and curate and bring as many resources that we know. But again, Jeanne, Tonya, and Grace, thank you so much for a phenomenal session. And I want to thank our participants too. So thank you for all you do to improve the lives of women, children, and families. And we look forward to having you again for our next session in July. Goodbye for now.
Thank you,
right.
Kenny. Bye-bye.
Thank you so much.
Thank you. Thank you
Thanks,
so much.
everyone.
Bye.
Bye.